Good day. My name is Dr. Ian Johnston. I'm one of the pediatricians at the Chatham-Kent Child and Adolescent Clinic. Today, I'd like to continue with our series that we have entitled ADHD, a Toolkit for Families. Our topic today is a very basic one. What is ADHD? In fact, this simple question is deceptively complex. I've been doing this business for 18 years now, and quite frankly, I've never come up with a satisfactory, short, concise description of what ADHD really is. It's quite straightforward to describe what ADHD looks like. There's good agreement on what criteria make up the diagnosis, and we'll go through these in some detail later on. But a description is quite different from a good definition of what a condition is all about. Some people will try to call it a disease, but these patients aren't sick. Other people will try to hedge a bit and call it a disorder rather than a disease. But even this isn't really fair. The very characteristics that are problematic when you're younger and at school can be a real strength when you grow older, particularly if your energies are channeled in an appropriate direction. Another statement that I commonly hear in the office is that it's some sort of chemical imbalance. To some degree this is true, because all behavior is chemical. For the same reason, however, it's not a very helpful concept. One could label any type of behavior that you find distasteful as some sort of a, quotes, imbalance, close quotes, and it certainly isn't helpful in helping one deal with a condition. So while there's some merit to this description, I really don't find it of much value in clinical practice. Finally, I commonly hear the opinion that this is simply behavior. This is bad boys being bad boys. In fact, ADHD is incredibly strongly inherited. It's very much in your genes. And these behaviors are not something that you pick up through moral weakness or poor parenting styles. Having come to accept the fact that I don't have a satisfactory definition of ADHD, I think of it simply as a way of being. It can be a very functional way of being, and in fact, some very high-achieving individuals have ADHD characteristics. Many people in my medical school class we used to describe as having ADHD. Many entrepreneurs have some degree of ADHD. Unfortunately, in many circumstances, it can be very non-functional. In particular, the school setting is one where ADHD characteristics can be very problematic. All right. So far we have this somewhat nebulous condition which involves some degree of hyperactivity and or inattention and or impulsivity. How does one go about making a diagnosis? At least now we're moving on to somewhat firmer ground. The criteria for ADHD are very well established. There are 18 of them. 9 of them pertain to inattentive symptoms and another 9 pertain to hyperactive or impulsive symptoms. These criteria are widely available. They can be looked up anywhere on the internet. I have posted them on our clinic website for your perusal. All of this is well and good, and I have heard some people say that ADHD is a diagnosis that can be positively made based on well-established criteria. Unfortunately, people who make statements like this don't live in any world that I'm particularly familiar with. If you look at the ADHD criteria, they're all extremely subjective. For example, one is talks excessively. What I may think of as talks excessively may be quite different from what you thinks is excessive chat, and maybe quite a different thing again from what the teacher thinks is excessive chat. Parents often come into the office asking that their child be quotes tested, close quotes, for ADHD, and this inevitably makes me feel very uncomfortable because I'm aware that the test is actually a series of 18 very subjective criteria. Although we would all like them to exist, there are no blood tests, there are no imaging tests, there's no EEGs, there's no computer tests which allow one to make a diagnosis. This is what we call a clinical diagnosis, which means it's a diagnosis made on a symptom complex. How the child behaves and how this is perceived can be very, very different depending on who is providing the report. In fact, I often say the diagnosis is far too grand a term for what I do with ADHD. I prefer to think of it as an educated opinion based on experience rather than anything concrete like a diagnosis. So what does ADHD look like? The three core components of ADHD are inattention, hyperactivity, and impulsivity. ADHD, however, comes in a variety of flavors, and one does not have to have all of the components to merit a diagnosis of attention deficit disorder. The most common type of ADHD is the combined type. This is the classic ADHD, the full house, so to speak. These are the kids who have all of the criteria. They tend to be active, they have trouble sitting still, they speak out without thinking, they're chatty, they tend to get in trouble because they don't think things through, they're disorganized, they're always losing things. Quite frankly, these children aren't particularly hard to identify. On the other hand, there's a separate group of children who are quite different. These are the predominantly inattentive kids. These are children, usually but not always girls, who do not have any hyperactive or impulsive symptoms. They can often be quite quiet, but in fact they're quite inattentive, they're forgetful, and they can be quite difficult to identify because they're not causing anyone any trouble. They're quietly smelling the roses at school while everyone else is completing work and learning things. The final and least common group of children are the purely hyperactive and impulsive children. These kids are able to focus reasonably well but have very high activity levels and are always acting out. These we see relatively infrequently. People will often ask me what the difference is between ADD and ADHD. In fact, the difference is really just a function of old-fashioned terminology. These days, all of it is described as ADHD. There's ADHD combined type, ADHD purely inattentive type, and ADHD impulsive/hyperactive type. So we're presented with a child who's either hyperactive and impulsive, or hyperactive, impulsive, and inattentive. The next natural question for a parent to ask is, why is my child like this? What have I done wrong? In fact, there's been quite a lot of research done in this area. At this point, there are no clear answers, but there are a few important things to keep in mind. First of all, ADHD is highly inherited. Just like a tall person is likely, although not guaranteed, to have a tall child, an ADHD parent is likely, but not guaranteed, to have a child with some degree of ADHD as well. And the degree that ADHD is inherited is even stronger than the degree to which height is inherited. This is a very genetic phenomenon. A number of genes have been identified which appear to play a role in ADHD. We certainly haven't found anything that can be said to cause ADHD. Some of these implicated genes seem to have something to do with neurotransmitters, but this is all very early days when it comes to ADHD research. At the end of the day, we don't really understand the details of what makes these children the way they are. From a somewhat more gross point of view, if one looks at the frontal lobes of children with ADHD, taken as a group, their frontal lobes are a little bit smaller than non-ADHD children, again taken as a group. Frontal lobes have been implicated in the management of decision-making and impulse control, but this certainly isn't even near a point where it could be used for a diagnosis. It's just an observation that people have made. Although it's tempting to think that imaging the frontal lobes or checking for various genes would help in the diagnosis, but unfortunately we're not at that point yet. Although one could test for these things, it wouldn't help us with the diagnosis in any way. How common is ADHD? To some extent, it depends on where you are looking, but there's surprising homogeneity from country to country to country. Generally speaking, the rates run around 6%. Some places, such as the United States, run a bit higher at 10%. But again, there's some variation from state to state. But the 3% to 10% range is seen in most societies that you look at. We are dealing with a common condition here. The next question becomes, do all children who have trouble attending in school, have trouble paying attention in school, do they all have ADHD? And the answer is very clearly no. There are a number of reasons why children may have trouble focusing in school, and certainly ADHD is one of them. I certainly see many children whose primary problem is simple ADHD. But there are other reasons as well. Probably next most common is the child who is struggling with the academics. I always use myself as an example here. When I am dealing with something that I understand, for example medicine, I'm very attentive. I can listen all day, I can take notes, I can keep myself organized, I remember things extremely well. But if we discuss something that I have no knowledge about and no aptitude for, all of a sudden I have a great deal of difficulty following a conversation. If one decides we're going to talk about nuclear physics today, I would last just a couple of minutes before I was off thinking about baseball or what I was going to be doing the next weekend or other pleasant things such as this. This does not mean that I have suddenly developed an acute case of ADHD. This means that I don't really understand physics. It's only natural not to pay attention to things that we don't understand. There are other reasons still. I always say if I have a fight with my wife in the morning, I don't pay attention very well in the office. And the children are exactly the same way. If they're concerned about something, if there are difficulties at home, if they're anxious about things, this certainly can cause inattention. If they're being bullied, this certainly can cause inattention. If they're depressed, this certainly can cause inattention. And in fact, inattention is one of the core criteria of depression. From a purely physical point of view, a child who doesn't see very well or a child who doesn't hear very well won't pay attention particularly well, or a child who is hungry isn't going to pay attention particularly well. Which finally brings us around to what does constitute an assessment for ADHD. Clearly, the 18 ADHD criteria are important. Equally important is keeping in mind that by definition, one has to meet criteria in more than one setting. A child who is just inattentive at school but is perfectly attentive at home and everywhere else does not have ADHD. So therefore it's important to ask the ADHD questions not just to the teacher, but to the teacher, to the parent, and any other caregiver who may have some valuable input. Equally important, one has to look for other reasons why a child may be inattentive and why the child may be struggling. Adding to the problem is the fact that many children come with more than one problem. I always wish they would come as either this or that, but this is often not the case. And in fact, we have 2 full lectures dedicated to conditions which are often found along with ADHD. So not only do we have to ask the question, is the child inattentive and is the child hyperactive, but we also have to ask why else may they be hyperactive and inattentive, and to what degree are various different causes responsible for the difficulties the child is having. One can see that this ends up with a fair degree of guesswork. That being said, any assessment of ADHD has to also include an assessment of academic and learning issues. It has to include an assessment of mood issues. It has to include an assessment of home and psychosocial issues. And it also has to include an assessment of medical issues which may be contributing to the problem. At this point, it might be useful to stop and look at an example. Let's consider Skyler, who's 10 years old. Everyone agrees that Tyler does not pay attention in school. He's always doing something else when he's supposed to be doing his work. He's always fiddling around with little things inside his desk. He talks out of turn. He gets upset frequently and often gets in trouble for hands-on behavior at recess. On the other hand, The same Skyler at home enjoys drawing pictures. He likes playing board games. He likes setting up his toy army men in elaborate battle formations. Does Skyler have ADHD? It appears that Skyler has ADHD at school and doesn't have ADHD at home. Unfortunately, this is not the way that ADHD works. By definition, ADHD symptoms must be present in more than one setting, generally at home and at school. At home, he can focus on a variety of quiet activities such as drawing and board games. On the other hand, at school, nothing at all. This is the situation where one has to have a relatively high index of suspicion for some type of learning issue as opposed to an attentional problem. On the other hand, perhaps he's being bullied at school. Perhaps he can't see the blackboard. Heaven only knows. But it's important to consider these possibilities because the story really isn't consistent with typical ADHD. And if the issue is academic or social or medical, a simple stimulant is clearly not going to help the situation. ADHD medications can be extremely helpful for focus when the problem is ADHD, but they're not helpful at all if the problem is something else. The assessment, therefore, is really a rather broad-based information-gathering exercise. One has to look at home, one has to look at school, one has to look at academic issues, but also one has to look at non-academic issues. Information gathering usually involves fairly extensive checklists filled out both at home and at school, as well as a fairly lengthy interview with parents and with child. All right, assuming that we now have a child who has undergone an assessment and there's general agreement that the child is inattentive and or hyperactive or impulsive, and there is no other good explanation for the symptoms. In other words, he meets criteria for ADHD. What now? The truth of the matter is, one doesn't necessarily have to treat ADHD. I always say to patients, this isn't cancer. One doesn't die with ADHD. The question really is the condition impairing the child? If the child is doing well academically, is doing well socially, feels good about themselves, gets along well with the teacher and gets along well with the family, there's no compelling reason to treat even if the child does meet criteria for ADHD. The question is one of impairment rather than just symptoms. Part of the assessment, therefore, is determining what degree of impairment exists. In fact, many children who have ADHD symptoms are quite significantly impaired, but by no means all of them are. And one can very reasonably ask, why would one want to treat a child who is functioning well without significant impairment with significant medications with significant side effects? Although there are certainly some ADHD children who function quite nicely without significant impairment, for the majority this isn't the case, and it's certainly a mistake to underestimate the negative impact of untreated ADHD on many of these children. Fortunately, there are some treatment options, and in the next part of this series we will discuss what the pros and cons of some of these treatment options might be. Thank you so much for your time and attention.